The device itself won't give oxygen. What does the device itself do?
Humidify.
Right? And then we don't use it above what liter flow?
6.
What is going to happen if we turn it that high? Where's Elijah? Or who else was with him that day?
It's gonna
Francisca's
whistle.
like, it was me. So the day I'm talking about, I think I've mentioned to all of you guys, right? But there is a little plastic piece that will be here blocking the humidifier when you first open it, okay? If you connect this piece and hook it up to flow without taking this piece off, the water is going to be pushed the path of least resistance, which we found out the hard way is through the threading of the humidifier, you guys, is where all the water is going to come out of this one likely, okay? So make sure you guys take off the little plastic piece that is hanging here.
Does it have it on there?
It does not. I can go get it all. You want me to go? I'll go get you one. Yeah, I'll go get you one.
Yeah, I've never seen the cap until it was just on there.
Oh, yeah, that's why we
Because
don't
I didn't
know.
even, we didn't even really yank it up. It was just the fact that there was
Oh,
just
when
a
it
cap
started
over it.
flooding that
Yeah,
day?
there was just a cap on it. There was a random cap.
Perfect. Here, go ahead and pass it around, guys, so you guys can all see it. This is the one I'm talking about, okay? And just pass it around so you guys can all see it. That is how it will come out in the package, you guys. So this portion that is threaded on is not connected either, okay? Which means there's no hole in the top of this. When you screw this piece on, that is what creates the hole to puncture. And then you have to pop that little plastic piece off the top, okay? These are pretty, you guys will deal with these a lot when you guys get into clinic. This is something that you guys usually get pretty familiar with, okay?
The Salter kind of works the same way.
Except for higher flows. Or
Except for we can put higher flows through it, and then because of the Salter having a diffuser, it delivers more or less humidification than that one.
More.
Because we can give the higher flows, you guys, right? So all this is doing is it's making up for the fact that we're doing higher flows by a larger water reservoir, right? And then also harder plastic so it doesn't blow up. But the diffuser, which if you guys remember from our labs, creates more bubbles. So you have more surface area. What are the other things that affect humidity? Surface area, temperature, and contact time. Perfect. Thermal mass is on there too, right? But that's the same thing, you guys, kind of as contact time and surface area to a certain extent. So you'll want to focus on those first three. Yep. Haha, you got it. Large volume nebulizer is what I told you guys this is called if you look in a textbook, right? Does anybody remember what it's called I told you in the hospital? Because we call it something different. Yes. That's what we'll probably call it, you guys, is they'll say, go get me an aerosol, okay? We don't, huh?
I said the big one.
That's the big bottle, right? They can look a different way too, you guys. That is one of them. The other one we have here at the college, which is less likely you guys will see it in practice, but it does require a little bit of work. So I like to show it to you guys. So like your bubble humidifier, this is a large volume nebulizer. The top that goes on it screws on just like your humidifier would, but then requires you guys to puncture your own hole for the Bernoulli's principle to happen, right? So you're gonna puncture, if you pass this around, you guys will see that where that yellow cap is a spike. And that's what you guys will do is screw on the top and then spike it in the front piece of the humidifier there, okay? So you will see them two different ways potentially. Either one of them has an air entrainment cord at the top, okay? Both of them will have that. Can I give medication with this device?
no.
Perfect. How do can I hook this up to air?
No.
Yes, you can.
That's how you.
Right? We can, because this thing limits us, you guys. If you look at it, I'll spin it all the way down. You guys can pass it around. What's the lowest FiO2 it says it can do? 28%, right? So it doesn't go lower than that. Go ahead and pass it around. It doesn't go lower than that. So if there's a patient who I have who does not need oxygen, I can still hook them up on this. I'm just going to hook them up on an airflow meter instead of an oxygen flow meter. And I'm not going to report any FiO2, right? If I report an FiO2, it's going to be what? 21%, okay? If I have it hooked up to air, it cannot possibly give oxygen, but it can give humidity, okay? And that you can heat too.
They only use that with air, just for humidity purposes?
If I had a trach patient who came in that's not on oxygen, that I wanted to give humidity to, but he didn't necessarily need the oxygen, that's the one time I can see it happening, you guys. And because that device is most often used with trach patients, I wanted you guys to know that little bit, okay? So yes, you can run it on room air. It is not gonna say on the device that it's room air. You have to physically know that it's room air because you have not connected it to oxygen. Remember, the reason that it can tell you the percentage of oxygen is because it knows with correct flow, if I change that air entrainment port, it's gonna train to my FiO2, right?
What's the correct flow?
What is the correct flow? Anybody know?
10 to 15.
It depends on the patient. I would start at about 10 to 15, but there's a rule. How do I know it's working correctly and how do I know it's working good?
If you can see the
Breathing.
mist,
You can see the.
you can
You can see the mist,
mist.
right? So when I turn it on, you guys, you're gonna have 2 lengths of tubing, right? No, you're fine. 2 lengths, that one or the one that you have, right? You're both, those are both gonna require 2 lengths of tubing, you guys.
This chapter of my life is
The
done.
reason we do 2 lengths is so that we can add in a drain bag. Why do I need a drain bag?
To prevent the humidification from going back into the,
Perfect. If they're gonna condensate, right? It's gonna create moisture. So if it creates a lot of moisture, the condensation will build up in the corrugated tubing. If you guys do not put a drain bag in line, that corrugated tubing is the only thing between the wall and your patient's face. So if it collects in there, you guys will not have anywhere to dump it if you do not put a drain bag in line. So you wanna make sure you have 2 pieces of your aerosol tubing and the drain bag, okay? Now, this device itself, hold on one second. This device itself, you guys, can be hooked up to multiple, I'm sorry. Multiple interfaces. What do I mean when I say interface?
The T-collar, the...
In your face.
Yep, in general, what is that? If I was to say a generalized term, you guys, what would a general term for an interface mean?
Adapters. That's what
different
I was-
masks that you can put
The-
on your face.
The piece that interacts with the patient, okay? So whatever that is, Armando is right, you guys. All of what you guys said are all interfaces, right? I have this one. What's this called?
That's the
Tray collar,
the
face
face.
tent, because I just told you guys.
The
The-
neonatal mask.
That's the aerosol mask, right? This one is a pediatric or a neonatal, probably pediatric one. Aerosol mask, and then the one that Francisca have that I'm just using here is generic, you guys, is the T-piece, okay? All 4 of these are patient interfaces, meaning that is how you connect it to the patient. Okay, so when I say patient interface, all I wanna know is you guys know how you're gonna connect it to the patient. So if I was to say, well, where's your interface? That's what you should be looking for, is how am I gonna put this on the patient or connect it to the patient? Okay?
So you would want the TP piece, or you would want all the components?
No, they're gonna be specific to each patient, right? So when would I put this one on a patient?
If they had a surgery or you don't want to put pressure on their face.
Yeah, if I don't wanna put pressure on their face like this one would, you guys, if it was an adult version. Obviously, it's not gonna fit my fat face, but if this was an adult version, this would wanna be covering my face, right? But it's gonna put pressure on my cheeks right here, as well as on the bottom of my chin potentially, and even more so, you guys, the biggest portion we have a problem with is in the nose. That's where it sits, right? So if you have a patient who goes in and has a septum repair, do you think they're gonna appreciate you putting a mask on their face? Nope. So then we'll do something like this. We were actually talking about that the other day, because you start your shift off bad. The first patient you have your treatment on, you snap them in the face with a mask, and then you're like, great, my day's gonna be fucking awesome, and then you just move on, right? So face tint, you guys, anytime you do not wanna put pressure on the actual face, you guys are gonna wanna use a face tint, okay?
Which one can you flip upside down? Was it that one?
That one you can flip upside down, yeah. So there is just a little, I don't know, divot, you guys, there in the plastic. That is actually meant to sit on the chin, so that this just kind of blows at them, right? This is not meant to have any pressure, any contact with their mouth or nose. It's just to blow it at them. As opposed to this one, this is the one we're usually gonna use, you guys, unless there's a reason for us not to, right? This one specific to a type of patient,
Trach
okay? When would I use this one?
for nebulizer.
Oh,
When they're getting a nebulization.
When you bypass the mouth and nose, right?
It's a trach, you guys.
Yeah.
This would be a T-piece, right? The difference is in your lab, you guys, I had the T-piece hooked up to the mannequin with a suction device, okay? So the difference between these is really, and this is, I'm not gonna test you guys on this, right? But the difference in which one you would grab. If I have a trach patient who has an abundance of secretions, I'm grabbing the T-piece and I'm getting an inline suction device, right? If I have a patient who's not maybe coughing up a whole lot, I'm just giving it to them for aerosol so they can get some moisture. then I can go ahead and give them this, right? Anytime you're gonna be repeatedly suctioning, you're gonna putting them on a T-piece. There is new research too, you guys, to say that suctioning, we're probably gonna start limiting our suctioning a lot more than we do in the future, just so you guys know, just because of the damage that it can do to the actual airway. That doesn't mean you guys, any of you are allowed to be scared by that, okay? We are all RTs, we're the ones that are supposed to know. So we're gonna be the ones that tell people not to suction, right? You guys, if you have suction and secretions that you guys need out, get them out, okay? But if it's a trach patient, you're gonna go T-piece with a Ballard is what we call it, but you guys will learn that later, inline suction. This one, if I don't think I need to suction all the time. Can I interchange in between these, you guys?
Yes.
Yeah, so at any point, if I put them on this and I'm like, oh crap, now I've humidified my patient who's trached. Now all of a sudden I have tons of secretions coming up. I'm gonna switch them over to the T-piece and hook them up to an inline suction. All right. I think that's all of the large volume aerosol stuff, you guys. Can this be considered high flow?
Yes.
No.
Yes, at
No.
less than 35.
Okay, what's the definition of high flow?
Has to meet or exceed,
It has to meet their respiratory.
Demand.
has to
It
meet or
needs to
exceed.
meet their inspiratory flow demand. Good. That is the definition, you guys, of high flow, is that it can meet the patient's inspiratory flow demand. Yes, you're right. That's about 60 liters is what we anticipate, right? That is why you guys, Armando also said that it can be high flow if it's under 35%, okay? I don't need to actually confuse your guys' brain with that. If you guys want to know more about that, you can ask me. But, oh, actually, this one statement might clear that up. How do I increase the total flow with this device?
Open the entrainment.
What does that mean?
Open it.
Okay, that means I make it bigger.
Mhm.
When I make that air entrainment bigger, what happens to the FiO2?
Close it.
The FiO2 goes down
There's more room.
because
But
you're
I've given
bringing
them
in
more
more room
flow.
there. Yeah.
Okay, that's the main difference, you guys, between these aerosol devices and those high flows, right? And if you guys have probably heard me say this before, but I'll say it one more time. The reason we don't use these anymore for high flow is because we found out they're not very good at delivering high flow. Meaning, if I want to deliver and meet my patient's inspiratory flow needs, I have to be at 35% or lower. And again, how many of our patients have an increased inspiratory flow need, but an actual decreased FiO2 need? Not very many, okay? So yes, can I use it as a high flow device? In the specific incident that you have a patient who only needs flow and does not need a lot of FiO2, yes, okay? But if your patient needs flow and FiO2, this is not the device that you are going to use. What am I gonna use?
Heated high flow.
I'm gonna go to the heated high flow, okay?
So that can be used for high flow.
Only if it's
Only.
under 35%, right? But that is not how the board is gonna define it for you. The board will define it as it meets your patient's inspiratory flow demand.
What about the Salter?
Can it potentially meet your inspiratory flow demand? Yes, right?
It's hard plastic. It can-
I can only increase it to what,
15.
right? So what it's gonna be dependent on is anatomy. And if your patient can then entrain more room air around the cannula by themselves in addition to what you're giving them, right? So if their need to get them to the 60 is only 15, then yes, potentially, right?
Right.
How am I gonna know if it meets my inspiratory flow demand? What should I see from the patient?
Decreased work of breathing.
That is what you guys need to know, okay? That is how I'm gonna know it meets my patient's inspiratory flow demand, okay? So if I was to put this on and go, okay, let's see, he was on a 2-liter cannula, so maybe he only needs less than 35%, right? We'll set it up. I'll put this on 15 liters, right? Put it on the lowest I can, so I can give him the more flow, right? So put it on, if he was on 2 liters, what could I put it on? This does not be 2 liters, right? It's FiO2.
28.
28%, good. So if he was on 2 liters, I can go, oh, okay. Let me put this on 28%, hook it up, turn it up to 15. That is the most flow I can give him because I cannot turn his oxygen down now. So do I see a decrease in work of breathing with that?
You should.
If I do, then I'm golden. Leave him on the aerosol, right? But if once I get that, I should understand that is the max flow I can give that guy. So if he is still, what am I gonna do?
Up there.
Change.
I can't go higher than 15 on this,
I know, go to high
right?
flow.
So then I gotta go to high flow. Perfect. That's the only way you guys get above that. Right? Same thing would be with the Salter mic. What do we want to talk about next?
Everything.
Everything.
On the study
Keep
guide,
going.
it says number 10, know the pressure that the most hospital equipment operates.
50.
Perfect. And what is that asking you guys?
What comes out of
If I connect to this
Back
port,
of the tree.
if I connect to this port, how much pressure is it?
50.
50. My flow meter will not work correctly unless it has 50 PSI, right? So I'm gonna connect everything that is a direct port, you guys. So when you guys actually get your equipment, so for your high flow, right, this has to be connected to 50 PSI. It's not gonna go to the front of your flow meter because that is not an automatic flow, right? When I hook up to the back here, we know that once we initiate that, it's automatic flow. So that's where we're gonna connect it, okay? So if you have a flow meter that has that back piece, that is always 50 PSI.
And that's the disk system, right?
Yes, and that is the disk system, okay? So this 50 PSI piece, this is always 50 PSI. If it comes off before your regulated flow meter, it's what's coming from the wall. All of your hospital equipment, you guys, will connect to this, meaning your airbows, your ventilators, when you guys learn IPV and MetaNeb, those hook up to 50 PSI as well, which we will learn later on.
What is the ASS abbreviation again? I know it's PIN for the piss, and then DIS is diameter system.
American Standard Safety
For the
System.
big tanks.
Okay.
American Standard Safety System.
I was like
Yes.
looking at them, but I was like, nothing makes sense to the A.
Yeah, American. America.
America.
Okay.
American ass.
High flow.
What's the other name for it? Large bore nasal cannula. Good. Or they might just say it's the Salter, you guys, because that's the one it's going to connect with, right? The green tubing is the one that is specifically for the higher flows. There are ones that are not green, you guys. So the way that you can make sure is it should be
Thicker.
thicker than your regular nasal cannula, right? When you guys fill your nasal cannula tubing, this one should be a little thicker.
It's large bore, right?
Yep, large bore or high flow.
And you said that only connects to the Salter?
You should connect it to the Salter, or you can connect it to the, I'm sorry, not that one. There is a larger humidifier, you guys. I don't think we have one here. I have seen in the past humidifiers that are like double this size that would be able to accommodate, I think, the 15-liter flow. I don't know if any of the facilities still get those.
Not on
So-
the test.
Nope, it's not gonna be on the test. If it's hospital specific, you guys, I'm not gonna put it on a test. So what you guys should realize about if you guys go into a hospital and they have high flow cannulas is ask them, which humidifier do you guys use with these? I know it needs a bigger one, right? Because you guys should know this is limited to 6 liters. So then just ask them, what humidifier do you guys use with this? Or do like what I would do and just stand in front of all their equipment and go, oh my God, I know. And then if your instructor's there, just be like, hey, what do you use for this one? Right? But if your instructor's not there, don't be afraid to ask the staff, you guys, what they use.
Ask the janitor. See
Which one do they use?
Might be the same.
But you should know though, right? This one is limited to 6 liters. So if you know this is a high flow cannula, you know you need something bigger or more sturdy, right? That's what you guys should actually know, is the bigger or more sturdy. What are these masks?
Air entrainment masks.
These are your guys' Right, they work 2 different ways, right? You can control what two
You can control
components.
the
Jet
air
orifice
entrainment and then the
and
orifice.
the air entrainment port, right? So you guys will have potentially contact with both of them, which is why we show you guys both of them, okay? If it is the air entrainment port that changes, or the nipple size, you guys will have an accompanied bunch of pieces that come with it. The venti mask itself, you guys, makes it a little bit easier. They only have 2 pieces that will connect to the end of theirs, but they will all tell you what flow and what FiO2 is accompanied with the piece that you put on, okay? The venti mask also tells you, but those are the 2 options they have. If it has the same air entrainment port size, then you are likely to be changing the size of the nipple orifice, right? If it has an adaptable air entrainment port, you usually are not going to have an accompanied jet orifice change as well, okay? But just know your manufacturer's guidelines, you guys. You should have different nipple, what you wanna remember about air entrainment masks are those that are the two things that can control your FiO2 and the accompanying flow. Is whether or not it's a jet orifice that it uses to change it, or the air entrainment port. Like I said, your clinical instructors in your facilities should be showing you what they use. It is likely that they will not show you any air entrainment masks if they don't use them. They can also use the high flow for a lot of in-between, you guys. So they might not use these. I know that that was my go-to when I was practicing, is I just totally disregarded any of that now, right? I know Armando, you guys was like, why do we learn all this? You guys learn all this because I cannot put you guys in one hospital and only teach you guys one hospital stuff. We have to teach you guys an overall of how the equipment works so that you can go into clinic, fumble with the device, look at the pieces and components, and figure out what it is. You guys should be able to identify it just by looking at it, okay? If your clinical instructors don't do that with you guys in clinic, go through the equipment, do it with each other, please. Okay, it will benefit you guys long term. You don't have to open everything in their stock room, right? But at least go in there and pick somebody in your clinic group and go like, please, will you go through these with me? Just to talk about what they are. What's this called? What is this? What do you think this is? There's gonna be equipment you guys haven't even seen. And you might actually have to ask people, right? But try to figure out with you guys, your group, what it is. You guys, if it's there, you wanna know what they use it for, okay? All right. This stupid mask. I know, I hate this one. What is it?
Simple
What's the
mask.
flows?
6 to 10.
6 to 10, 35 to 55, and don't use it under 6. Why?
CO2.
You're
Because
gonna
CO2.
rebreathe too much CO2 potentially, right? Potentially. It's all theory, you guys. Okay, what's this one?
Small volume nebulizer.
Okay, and this one is specific. It's got a
Breath
fancy
actuated.
Okay. And then what's the fancy thing that this does?
It only goes one way, so you can't breathe out. It only goes in if you breathe the meds in at the
Well, you
rate.
can change it to manual.
You
Yeah, you
only
can
get
change it.
meds when you breathe in if it's in the breath actuated mode. Perfect. How do I know the breath actuated mode is working?
The
No.
bubble.
The
pop.
ball.
The button on the top is gonna move, right? You'll also hear it, okay? If my patient can't initiate the ball to drop, what am I gonna do?
Switch the top.
Turn it on the top. Perfect. Goes to continuous. I shouldn't have any problem initiating. How do I know what's a good way for me to check and make sure they're actually getting it?
If you see them.
Look at the mist.
Look at the mist. Where's it gonna come out on this device?
The bottom.
Haha, that's the exhalation port on the bottom, right? So that's where it'll come down, you guys. And then, how do I put meds in this? You gotta unscrew the top of this one. Remember I told you I don't like you guys to unscrew the top, but this one, because of how it works, you gotta unscrew that top, okay? And infection control, you guys, make sure you try not to touch all the pieces on the inside when you take it out to put the meds in, okay? And don't set it on,
Oh, damn it. fell on the floor.
right? Like, we don't know what they're putting on their bedside tables. That could be super gross, you guys. So because it's on the inside of this, I would treat it just like you would a trach patient's inner cannula, right? Don't set it anywhere it's gonna pick up gunk. Lily, what's the one in front of you?
That one is a continuous neb.
Good. Okay, some type of continuous neb, you guys. It has a larger volume that you can give. That's how you would know that. Every continuous neb that you guys come into contact with, in the packaging, will have a paper insert that you guys are always gonna wanna pull out. Every one of them is a little bit different. What it requires for medication versus the amount of solution that you're gonna add to it to make it run a certain time. But it will all be on that handout that you guys get. It will tell you, use this much medication, use this much dilution or solution dilute, and then you should have a total volume of this if you want it to run this long at this flow. It is very specific to the devices, okay, you guys? So if you run into, or you don't see, say you're going through the equipment and you don't see anything that looks like a continuous neb, ask them, hey, how do you guys give continuous nebulization? Or do you guys use continuous nebulization? And see if they have a device that does it. And you guys will likely see it as a large volume cup that it uses, okay? What do I run the flows at with that? Whatever the package insert says, right?
Damn.
Whatever the package insert
I
says.
never even saying anything.
Nope, I didn't. It was a trick question because I just told you guys it depends on the package insert.
Is that
This
extra
one
credit?
does have a set. I'm not sure. This one does have a set flow.
6 to 8.
6 to 8 liters is ideal, okay? And Can I give medication through this?
Yes.
I am this one limits me, you guys, the top line that I can see is actually 6 cc's, which that's like 2 Duonep treatments, 2 albuterol treatments. So that would be the equivalent of giving like 5 milligrams of albuterol, which is why if we need to give 10 or 20, we have to go to something like that, okay?
The baffle,
The component.
how the baffle works.
What's the baffle for?
To break down the
Break down
microns to the right size.
medication and to
What particle
minor
size are we
X,
looking for?
1 to
1 to
5.
5.
Where is that even gonna deposit?
The lower airways.
The lung periphery, right? That's the other fancy terminology you guys will see. What's this for?
Corrugated tubing is where the excess goes out.
That's where they're gonna exhale, right? So when my patient breathes in, how I can see that they're actually getting the mist is when they exhale, it comes out this way, yes? That is also you guys to enhance deposition, right? Does anybody remember what we said? If you give your patient a mask treatment, it decreases deposition to how much? This is not a test question, you guys. This is just for you guys to understand the reality of what you do for work.
Is it 10%?
No,
Oh, it's 1%.
it is 0.75%. Okay, so you should know. Remember how in the beginning of this class I told you, oh, they don't have any data to say whether or not a mask or a mouthpiece is better. I clearly said that in your guys' PowerPoints, right? It was about, I think, a little over 1%, I think, for the mouthpiece treatment, you guys. And then 0.75% is all they will get if you guys use a mask treatment. You guys will see that pretty early on, or maybe you guys noticed when you guys were over here, oh, you guys all have mouthpieces. You guys will see it then when you guys are in practice, because the difference is I can inhale all the medicine that comes out of this, right? So it's how much medicine I get is dependent on how much flow I can generate, right? What happens when you guys put a mask on the patient is when you turn the aerosol, right, it's on continuous. So what happens is when they're exhaling, the mist still produces and just flows out into the air when they're not breathing it in during exhalation, okay? Same thing happens with the mouthpiece, you guys. I feel like they just are more conscious of their breathing pattern when they have the mouthpiece in their mouth because they're understanding I'm getting medicine, right? Versus if you put the mask on them, they are likely just to and just breathe normal. They're not going to pay attention necessarily to their breathing. But this is also why we stay with them. We stay with them during their treatments. Don't put it out on the internet anymore, okay? Stay with them during their treatments.
No, just kidding.
Right.
This is going to the board.
I know I'm pretty entertaining, but whether I'm not, I'm educational, I think is the caveat there. Okay, what's this one? Good.
Non-rebreather.
How much flow is this required, or is required for this one?
10 to
Set-
15, or 8 to
Is it
15.
No, 10 to 15. 10 to 15, you were right the first time. I would start at 10 anyways. But really, what am I looking for, you guys?
1/3 to half
and
full.
1/2 full.
The bag to be full. During
Exhalation.
inhalation,
Yeah.
right? So when my patient goes, I want this to still be full, at least that little bit, to guarantee that the oxygen is having enough contact time to get and hopefully somewhere close to 100%. Okay, that's what you're going for, you guys. You guys will read a lot of literature potentially that says that this was only reliably delivered between 75 and 100%. They're giving you guys that range because they're basing it on the variability of how patients can breathe. Okay, if you guys have this seated correctly, right, sealed pretty nicely, and your bag is inflated during inhalation, you will be able to deliver pretty close to 100%.
No humidification.
Why?
One-way valve. One-way
It's a
valve.
little one-way valve, you guys. If you play with it's just like a little diaphragm. So what will happen is the condensation will get on it and it will stick. And then of course we don't know what my patient's actually getting as far as breathing or breathing into the bag. Turn. I can't. Oh, here's the drain bag too, you guys, that I forgot.
Oxymask.
Oh yes, oxymask. And I see I took the tag
You
off.
took the tag off?
Oh,
That was mean.
You're gonna leave them on.
so evil. All right, so what does this flow do? Or what does the flow to this one?
1 to 15,
All of it.
24 to 90.
All of it, right? It's just all of it, you guys. That's what it is. So if I have an emergency, this is a good device for them to put them on, right? Or do I even know if they need higher flows, right? If I crank them up to 15 and put them on this, and they can't get or they're not doing okay, this is not as confined as a device as your aerosol would be, right? If you were to do a large volume aerosol at the 15 liters, obviously there's a lot more flow that can escape on this. But in a temporary situation, these are pretty nice to have with that wide range of FiO2, okay?
I think it said that one's the most accurate, right? 502, I think is what it said.
Did it?
I thought it had the widest ranges because you can bring in all the room air depending on how they breathe.
That it is. It's all the patients
of the
breathing,
holes.
right?
But
Yeah.
it's better to communicate with them and when you need access to their mouth.
Yeah, or if they're
Right.
claustrophobic, you guys,
Yeah.
is really the big times
You're
I've seen
drawing
that
it
mask
there.
used is in the claustrophobic stuff, because when all those other masks are just so confining, and you can feel your hot breath when you breathe in them. When you put that oxy mask on and the flow's on, you can't actually feel your hot breath, so it's kind of nice. You don't feel like you're suffocating as much, and that's why people like that
Yeah, I
mask.
wrote everything down.
And then of course, you guys,
You're
nurses like that
suffocating.
mask because they have a wide range, right? So they can very quickly, all they have to do is control one device. They don't have to call me about the high flow and come change it if they have a patient on an oxy mask.
You know, a lot with NG tubes.
Oh, yeah, that's a good one
That's what I
too.
see.
Less pressure on the nose too, because you don't have to put it on so tight. All right.
What are you looking specifically for when you are asking recall how to properly set a flow meter?
Somebody knows the answer to that.
The flow
Is
meter,
that parallax? Is
you
that-
have to
Or
be,
lack of parallax, right?
Okay.
Turn it on, and then where are you gonna, the ball?
has
is
to
gonna
be eye level.
Midpoint.
Right,
when
so
you-
And look
whatever
at the
line
center.
I'm going by needs to be at the center of the ball,
Okay.
right?
I just
So
wanna double check that.
I want you to be able to show me what is 2 liters, or tell me that that is 2 liters, right? You guys, I'm sure can see too, when you look at a flow meter, there's a bunch of in-between lines on there too. You will have some people who will chart 2.5 liters, right? You will have some very specific patients who will be like, nope, I'm on 3.5. So just make sure you guys they're not gonna be looking at the flow meter all the time, right? And you guys will, long term, you guys will find out we sometimes lie to our patients about what the flows they're on anyways. But when you guys are looking at it to set it, I just want you guys to be able to go, that's 3 liters.
Okay.
I'm looking, questions? I feel like the clear eyes guy. Oh, Bueller, there was a guy who they called for the raffle, you guys, at the AARC conference, and his last name was Bueller, and he didn't show up.
No way.
And 1,000 people in there. They were like, okay, is David? And they were all, Bueller? Bueller? And I was like, oh, it was hilarious. It was great timing. Okay, now the ones everybody's are afraid of, okay? Let me first start out by saying these 2 devices are the same, okay? They are interchangeable. Meaning, if I have a patient who they say, I want heated high flow on, when you guys run down to the department to grab the equipment, both of these, if set up, will work, okay? I was telling you guys that you guys will not see both of them in practice because that was my assumption, because they do the same thing. But after we're talking to Mariah, she says that she's seen both of these you guys at Reading. So I can't tell you guys that anymore. So if they ask you for a heated high flow device, this is what you're gonna go for. Am I going for an OptiFlow? OptiFlow, and if you guys forget the name, it's on the generator, right? It's on the little piece you guys add on. Or this is called the Airvo, okay? OptiFlows use, what's this device called?
Blender.
Okay, blender. This does not, Airvo does not use a blender that you can see, right? There is a blender here, you guys, that's how it works. But it is not in this format, okay? That's how they can be the same thing. This one just uses a blender. Both of them require 50 PSI, but we know that with a blender, we have to have what hookups?
Oxygen.
Oxygen,
Air.
good, okay, and air. And you guys should know, right, these are our disconnections. Air is always going to be
Yellow.
and oxygen is always going to be
Green.
okay.
Brown.
Okay. Brown.
Are you gonna want us to be able to describe them differently?
No.
Is that why you're showing us both of them, or just showing us?
I'm showing you guys both of them because the controls work different too, you guys, right? On this one, how do I control the flow?
With the
The
flow.
third-
With the flow meter, okay? On this one, how do I control the flow?
With
Buttons.
With the buttons. All right, how do I control the FiO2 on here?
With the blender.
With the blender. How do I control the FiO2?
Buttons.
But also the flow meter, but with the blender, right? This is where the confusion comes. This one, I control the flow with the flow meter. This one, when I touch the flow meter, I'm manipulating FiO2. Okay, and because those are 2 very different concepts, I want you guys to be clear on that's what you guys are doing with the machines, okay? So, when I touch this flow meter, I'm going, my patient has increased work of breathing, he needs more flow, okay? When I touch this flow meter, I'm going, my patient's SpO2 is low, he needs more FiO2. That's a confusion I can't have you guys do in clinic because I don't want you guys screwing that up. If I have a patient who needs an increase in FiO2, it is always because the what value is low.
Their SPO2.
Their SpO2 is low, okay? If I have a patient who needs an increase in flow, it is because they are displaying signs of
Worker breathing.
shortness of breath or increased work of breathing, okay? That will be increased work of breathing. If you guys have a cardiac patient, they are still going to display shortness of breath, okay? That's in fact, usually the shortness of breath is why we catch what's going on, right? But they're still gonna display shortness of breath. You guys will have a whole patient assessment portion too. I know after talking to Emily, we got to talk a little bit about our curriculum and our 2-hour plane ride. So you guys will have more information on patient assessment, but tell me what you guys know as signs and symptoms of shortness of breath.
Using accessory muscles.
Accessory muscle use, wheezing. What do we call that in fancy terms? Tachypnea, good, right? She said increased respiratory rate, you guys. Chest tightness, okay? Pain, they might just say they're in pain, yep.
Color.
Tripoding, color. What's the fancy term for the color we don't want to see?
Cyanosis.
Right? Okay. If cyanosis is here, are we more or less worried than if it's here?
Essential cyanosis.
Less worried if it's here because it's
Peripheral
farther away,
cyanosis.
right? Peripheral cyanosis. We're more worried if it's centrally located. Okay, good. That's all good, you guys. Okay. Tachycardia can be another one that you guys can see. Sometimes that is an early sign of. Okay, so if their heart rate starts to go up and they're trying to, their heart's telling them I'm working harder, right? Then that's going to initiate them going, now I got to breathe faster too. Is my heart's working, right?
And that's myocardial output. Is that pretty much?
Yeah. Right, it's going to be dependent on their cardiac output is probably what it'll be. But also it depends on what's actually going on, right? Because is it medication induced or is it something that's going on with the lungs that we're now seeing the signs and symptoms of? It'll be a lot, you guys, right? What you guys need to know is anytime your patient's short of breath, if I'm on one of these machines, what am I going to do?
Increase the flow.
Increase the flow. Good.
How do you turn on the heat on this guy?
The button.
And this one is the same interface down there?
You press the on button, right? And then you have temperature controls on this one. You do have temperature controls on here too, but there's only 2 of them. I have an invasive and a non-invasive. And all I do is push and hold the button to change in between the two. When you push and hold the button, it'll change, the light will change. Let me show you guys. Also remember too, you guys, I know we plug them in and turn them on in here a lot. These heaters will burn up if we don't put water in them long term. So when you guys are in facility, you are always putting water in these. Okay, we won't turn the heater on unless they are, do have some water. That's the alarm, okay? You guys can see over here, there's a little green light. Right now it's on the invasive. If I push and hold it, it'll beep, and then it switches to the non-invasive. The invasive on this is always 37, and I learned from actually Lisa Morales, your lab instructor, the non-invasive is always 34. On this one, I have the option to go a little lower and go to 31. Now, when would I change the temperature on them in general? When would I want to turn it down?
If there's too much condensation.
Right, if we've met our condensation and we have a lot of water in the tubing,
Or the patient, so it's still on.
if the patient complains about the heat, I would also turn it down. Yep. If they're feverish and the nurse is like, hey, they have a fever, we don't want any extra heat, that's another reason you would turn it down. Good.
And
Yep.
you don't need to have the heat and moisture on, or is that?
You do. Actually, you don't have to, right? If I was to hook this up, you guys, and not have the heater on, they would still get moisture.
Right.
We would call it then just passive humidification. They're just not going to get as much humidity as if we were to turn the heat on, right? So if I have somebody who's continuously putting all kinds of condensation into the circuit, if I have this one, I can just turn the heater off, right? In order for me to turn the heater off on this one, what do I have to do?
The play button.
Turn off the whole device.
Oh.
Okay, so on the Airvo, I cannot independently turn off the heat. On the OptiFlow, I can. On the Airvo, my only option is to go all the way to 31. Sorry, guy, that's the least temperature I have. If it's bugging him after that, if it's a bug and I have this as an option, I might switch him over. But you could also just try to go to maybe a Salter. See if you can trade his FiO2 if he doesn't need that much flow, right? If he's still short of breath, you're kind of in a pinch. Okay. You look so excited. You're so excited right now. I love it.
Randy,
Yes.
so what would be the difference?
But is that why they're
The effects of low humidity on airways versus the signs of
Hey, say that out loud again. Vanessa had a good point, you guys, because I think I wrote it 2 different ways on your guys' study guide. I asked you guys to know the signs of a humidity deficit and then know the signs of lack of humidity. Are those gonna be the same thing?
Yes.
Okay, I put it on there twice. Just, she thought it was a trick question. This is me saying it's not a trick question.
Will we be having to do any humidity calculations on that particular
Yes.
question?
Oh, on that particular question, no, but there are questions about humidity deficit on the test.
From the lab.
On the
For the
lecture.
Lab?
lab test or
Not
lecture?
the lab.
Oh, it's on the lecture test.
Yeah, I was
Okay,
like-
thank you
But
for
are we
clarifying.
doing the
I was like,
calculations with like the PSI or the?
cylinder?
Yes, you will
The
be doing a
cylinder,
cylinder
yeah.
calculation on your exam.
Okay.
Okay, so let's talk about that. All you really need to know is E tank and H tank, okay? Your E tank has a max pressure of what?
22.
Okay, and what's the safety factor?
500,
Okay, what's your escape factor?
0.28.
Okay? And then your H tank, max pressure?
500?
2200.
Trick question, you guys. All
Oh, the
tanks are
same.
2200, okay?
200 minus 200.
Safety factor, 200.
Times
Escape
3.14.
factor,
3.14.
pi. Good
That's how
point.
I know
Oh.
it.
Yep.
Yeah.
3.14159. I still even remember out to 6 digits. That's crazy. That's like 3rd grade.
Cheating. You're like a math professor.
No, I just remember stupid shit.
Long name.
Being smart and remembering stupid shit are different.
Fact checker.
He's gonna go to Sweden.
I can tell you that when I was a kid, I was 7 years old, we went to a NASCAR race for whatever reason. I remember we got there at 4:14 a.m.
You still remember.
I still remember because I was tortured into waiting in line at 4:14 a.m. as a 7-year-old
For NASCAR?
because my dad is a redneck fucker and wants to go.
I
to
was like,
NASCAR.
NASCAR?
But I mean, if you guys haven't heard my story, it doesn't fall far from the tree. I literally got my COVID shot so I could go to NASCAR.
Oh yeah, you told us that in lab.
Right? I always say that. Like, it's so ridiculous. Boycott it the whole time you're working with a bunch of COVID patients and then be like, oh, I gotta go to NASCAR race. Give me that thing.
No NASCAR. It's all Final Destination.
Yeah.
Thank goodness.
Questions?
HMEs.
What is it? What is an HME? Okay, here's a baby one. Let me see. I'm gonna dig through Emily's stuff. You guys pass this around. It only goes one way, right? You gotta put it
Heated
in.
moisture exchanger?
Right. Look, I'm
Yeah.
gonna see if I can find you guys an adult version.
I know that they're good for only short.
I don't remember what they're for at all.
You're gonna be the only one to get this question right.
She actually has this exact
They
version.
add,
What is it for?
In the circuit.
and they add resistance.
I just read it. What is it for? Why do you do that instead of a human?
You said
We do that in exchange. So at home, she was on the humidifier, but we would put that on her when she was traveling.
Okay, so where do they go?
Because you can't take the humidifier
Humidifier
with
with
us.
you,
Yeah.
I think that top part.
So we would like pop that in between her trach and her circuit.
Do they have to take this out?
Well, if you can't get to a humidifier,
Heat moisture.
you can use that. as
Yeah.
a-
And then there's another one that's called the artificial nose, and she currently uses that. And we just attach it to her inline section when she's sick.
Transportation.
Yeah,
I think it's an amazing.
Like,
Yeah.
hey, they need
Yeah.
heat.
Okay, so then this would stay on her?
Like,
I'm pretty sure.
humidity is just for transportation. You don't leave.
A mini
long
net.
term.
Trina, is there one on that circuit behind you, Rennie?
ChatGPT told me
There
that.
is not. I'm looking at it. There's not one.
Randy, for this one, what's the blue part for?
How do you connect it?
And how do you breathe from it?
And see breathing.
I think we have some in our bags.
Do you?
Yeah.
Wanna grab? Will you get in your bag and see if there's one there?
I took my bag home.
That's
Okay, mine.
Yes. There's a TP6.
That's
It will come
tried
with
it.
one.
That's what I
Or
was
I'm
like
telling you
right
guys, we have adapters for everything. We'll figure it out. But this would be the
Sorry.
Okay, okay, so.
This is not for, the only thing I can think of that I might use this for is to put more medication in it and not take it off the patient's face.
Would you do air or oxygen?
It depends on what my patient's doing. If my patient's a kid and he doesn't need oxygen, then I'm not gonna give him oxygen. If he needs oxygen, I'm gonna give him oxygen. And if his
what the hell
oxygen
I have in
requirement
me.
is higher than the flow
And I'm
that I
not
can
taking
deliver
that back
with
until I
this,
pass my
I'm gonna
final.
need to give him supplemental oxygen.
You're not taking it home?
Not till I pass my
Okay, so let's rewind. Okay, you guys, so say when I open this continuous nebulizer, it says on there, for me to give 20 milligrams over an hour, I need to run it at 4 liters per minute. Okay? But I already have my patient on a 6-liter nasal cannula.
Oh, could you just put him on 2 liters on the nasal cannula and then 4 liters on that?
Wait, what was the question?
Okay.
What was the question?
My patient is on 6 liters nasal cannula,
Okay.
and I get asked, I have to do a continuous neb, and this directions that I pull out say I can give him 20 milligrams over an hour, but I have to run it at 4 liters flow.
I think you're right, but why would you do two things? You can do one.
You can, no, okay.
No, but she's
The
saying
equivalent
you
is
can
what
do
we
one
need
and
to deliver. Okay, so Lily is correct to say that if I'm going to give him this and I turn it down to 2, but I'm probably not going to turn his cannula down, honey,
You're-
right?
So then you would just.
So you're probably going to give him both, right? Then you need to pay attention though. If your patient is sucking on this at only 4 liters at that time he inhales, is he going to be getting the oxygen from his nose?
Oh.
Is your nasal cavity though connected
Yeah.
back here somewhere?
So he's getting both, isn't
So
he?
maybe he's getting, this is all skeptical stuff, you guys. I'm talking to you guys. This is me talking to you as an RT.
What is the data say?
Well, if he has his nasal cannula on, he's still getting his 6 liters, and then he's still, so it wouldn't matter. We'd still set that at the right, what it says to do on the direction.
You have to run this the way at the 4 liters to get the 4
And I
liters,
would
right?
leave
You're
the
gonna run
flow
that
the
the same.
It's not gonna
Okay?
hurt him, right?
The what would probably happen in the real world, you guys, is I would just leave his cannula at the same and hope that he's able to pull enough through the upper nasal passages to be able to maintain his sats with this when I give it to them, right? But if I give this to him and he's holding it and I can see that when he's doing the breathing treatment, he's desatting, what am I gonna have to do?
Crank it up.
I can't. It said I can only run it at 4
You're
liters.
gonna
You
stop it.
increase your nasal cannula.
Couldn't you put him on the small volume nebulizer?
You don't stop the treatment if they're not responding
How
well.
do you do if they start declining?
Well, that's a good question too. Let's revisit that, please. Can we revisit that, please? Don't forget that. Okay. What was your? Say it again.
I said, wouldn't you put him on a small volume nebulizer?
I can't deliver continuous nebulization through a small volume nebulizer, though, can I?
No.
Can we increase the flow of his nasal cannula?
It says to run it. Oh,
Decrease the flow.
Can
he
I
was at
increase-
6 liters.
Oh,
But
then
if
you'd have to
he's-
switch masks because nasal cannula only goes 1 through 6, right?
Yeah.
Couldn't you put him on the one with the holes, the oxymask?
How am I gonna give him this?
When I switch to,
that too?
That's what I'm saying. So
How
he's
long
got
does that continue?
an hour for 20 milligrams.
can I
is
do
what
a
told you
high
guys.
flow nasal cannula and increase his flow?
We're not worried about the flow at this point, right? What are we worried about?
We're going to make sure his FiO2 and everything is where it needs
You
to
guys,
be.
okay, the point here is you guys have a lot of options, right? You just need to understand that by setting this at 4 liters, you are not giving the same amount of FiO2 as what you set his cannula at 6 liters. So you can't just set it and forget it. This is just for me to say, you guys, I'm not gonna go, okay, Heidi, take this treatment, I'll see you in an hour.
Not supposed to.
Continuous nebs are actually different. You guys, we do
Yeah,
get the option to walk away from them and come back every 15 minutes. But you're right? You're just not going to set it and forget it, you guys. You should understand that by this thing saying I can only run it at 4, I'm giving less FiO2 than my 6 liters. So you cannot walk away. I have to figure out something else. I need to see how my patient's going to tolerate it. Can he tolerate it this way on the 6 liter cannula and holding this in his mouth just fine? Yes, maybe. Okay, the more short of breath he is, the less likely he's going to be able to maintain. But yes, he could potentially do it. Okay, your other options would include you can give these guys by mask. Okay, so if you have a mask, they get less deposition, but my FiO2 is maintained during my treatment. What are we fighting with here, right? This is where you guys get to choose, right? Is my patient more short of breath or is he more hypoxic? And then you guys do that, right? But you guys just don't want to take them off the device they're on. In addition to is always better. Give them more oxygen for the treatment, who cares, okay? That's just like saying the same thing, you guys, if I have a patient who comes in and I'm told they're in the 70s, what device am I gonna pick to put the patient on, probably?
High flow.
Okay, this thing, that's gonna take time, okay, I'm gonna set it up. Give me a second.
Non-rebreather.
Non-rebreather's likely where you guys are gonna go, right? Because I know it's 100%. It's the most I can give. Once I get them on that, then can I go get a high flow? 100. That is exactly what I'm gonna do, right? Especially if I see worker breathing. But I'm gonna temporarily fix the situation, watch his oxygen climb, then go, I'll be right back. You need something a little bit more. And then go get your device, right? You wanna make sure that you never panic and just go, oh, I can't put him on 100% because 100% is bad, right? Yes, we know that oxygen is toxic. Yes, we know that it's gonna cause damage, but when does it cause damage? Do you guys
It's over
remember?
a period of time.
Prolonged periods of.
Prolonged periods of time of
50.
high concentrations of oxygen. So if it's only 10, 15 minutes for me to get this guy from 70 to 90s so that we can not have him code or do anything else weird with his rhythms, then that's exactly what I'm gonna do is stabilize the patient, then see what device do I need to go to, right? It might be that I only give him a nebulizer and the nebulizer is just what he needed. His respiratory rate comes down, he's good to go. And then I can take him off the non-rebreather and titrate the FiO2, right? You just don't wanna hesitate with the hazards and complications. Those are just for you guys to be aware, not for you guys to not treat.
So all that's gonna be on the test.
Yep, all of it. All of it? No.
Where is it on?
It will literally be station 1, right? There's a piece of equipment, it's gonna ask you questions, you're gonna walk to the next one. Station 2. Piece of equipment, it's gonna ask you questions.
Okay.
Like, will it,
Station 2.
What I just did was all examples,
And it'll
baby.
just be random, you'll just pick randomly
Yeah.
stuff.
Well, I mean,
It's not gonna be all of this.
oh no, there's only 7 stations, this is way more than 7 pieces of equipment.
And you're not gonna leave the stickers on any of the masks.
And I'm not gonna leave the oxymask sticker on the mask, no.
the corrugated
Mask will be on there. There's one.
This would likely be called a mouthpiece, like a neb mouthpiece. If you're specifically talking about this, yes, corrugated tubing.
And that's corrugated tubing
Yes.
as well.
How much we're struggling with that, probably that one.
To a tray?
It's gonna be shit.
With the tray.
I would probably, yes, you could do it with a T-piece, but I would probably most likely do it with the mask, the tray collar.
What's the largest flow with this one?
Humidifier.
It dependent on the one that you have to pull out the package insert.
That's
Continuous
the one I got
nebulizers
it.
are, yep,
Okay, but I could do 10 milliliters of.
but you can do 10 or 20 or whatever, yeah, whatever they ask
So
for.
if you were to ask us, like, for the continuous nebulizer, what the flow would be, we would just say according to package instructions.
Yeah, I'm just not gonna ask. Damn it. But yes, that would be, if your clinical instructor says how high do I run the flow on a continuous nebulizer, what your answer is going to be whatever the manufacturer's guidelines recommends.
Okay.
And what's
Would you-
question 1 on the test?
Would you necessarily
Unless
use
it's
this
safe
with
there,
the
I
trach
forget
patient?
what
Only
it says.
because if you could
I'm
only
probably-
run this at 4 liters and they needed more than 4 liters, how would you?
Oh, that's a good question. Go ahead, do you know?
I was gonna say you'd have to do a secondary.
Like a second
Source.
T-piece,
Okay.
like another.
Okay. Let me give you this too. Remember I told you guys carry these.
Yeah.
Dude, you have to think about this.
Yeah.
You do.
A
So
scissors.
what you guys can do,
Scissors.
go on.
Go on.
Remember I told you guys, I don't care if you guys have scissors, but you guys are always our saviors when you have them, right? What you guys can do is, this is going to come in 2 ways. It might come like this, you guys,
Or
or
that giant box she showed us.
it's
Like,
gonna
I
come
already
like
ordered all
this.
that shit. She better pass me. I'm gonna get my refund.
Okay, so if it comes out like this, then how do I set up the aerosol, right? I'm gonna have to,
Cut it.
right? I have to count the rings, I have to go in here and cut it, I have to have 2 lengths of aerosol tubing. Yes, it's a big production, you guys, but you still have availability to it, right? Either way, I can cut this tubing and put a T-piece in mine. They have T-pieces, you guys, that are actually adapted for breathing treatments. You guys will see them when you're in your vent stuff, okay? But it would basically go like this. And it has a cap on it that you can close. So it's infection control safety, right? But it has a cap on it. So if you guys have a patient who is trached, needs the humidity and the flow from the large volume nebulizer, as well as you want to put a treatment in line, this is how you guys can do it. You just T-piece it in. Is it ideal to have this much corrugated tubing between my patient and their treatment? No. So what you guys would end up doing is about 3 or 4 links from the patient's face is probably where you guys would put the T-piece. And so it's close enough to the trach mask that you guys know that you'd be giving okay deposition. Never
But
gonna be
wouldn't
great.
you want to make sure that they can tolerate having the T-piece in line? Because doesn't it create dead space?
It does, but if you have a patient that you're doing a temporary treatment on, you're likely to make up with the dead space
Okay.
from the extra flow from your nebulizer. But that's a good thought, you guys. That she's saying once we add this in, right, that adds that little bit of dead space. So is it gonna mess with the flow the patient actually gets? Yes, but remember you're adding in flow.
Would you still have a bag on there?
Yes, you would still have to drain, and actually the,
Do this?
So
uh-huh.
you would need another corrugated tubing.
No, I'm just
attached
gonna,
to that,
I'm gonna cut the
attached
one.
to that one.
Yep.
And
I'm
then
just gonna
put-
cut the one I have, you guys, is what I'm gonna do. There's gonna be a short piece of tubing, and then a T piece, and then a longer piece of tubing, then a drain bag, then another piece of tubing, then the large volume duct. Do you guys?
Resistance to
Okay.
flow.
Now, are you guys seeing why we don't use these anymore?
Yeah.
That
is
sounds
exactly
really
why.
annoying.
Okay.
It's too much.
Not to
drama.
mention they don't work.
You're missing
But then
key
you guys
parts.
are all gonna be doing IS with patients, so not everything translates that way. Okay.
But IS is good for coughing.
But IS is good to make them cough. Yeah. And what do you think actually makes them cough when they do an IS maneuver, you guys?
They're inhaling.
Increase. It's the work.
Deeper breath.
The work in the lungs. But like, what specifically do you think is happening when we make them take a deep breath?
Opens up their alveoli.
What do we call that? Recruitment maneuver. They're doing a recruitment maneuver, you guys, and as their alveoli start to open, the changes that happen in the airway can sometimes cause a little irritation, which is usually what initiates the cough, right? They have some shifting of whatever, or their cilia or their whatnot. Oh, that was another cool thing we got to see at the conference. Sorry. Squirrel. He had him under a microscope, you guys.
A squirrel?
No. Follow the squirrel.
You put a squirrel in there? What kind of conference is this?
Squirrel was my shift. Squirrel was my shift.
Oh, I was like, I don't want to
Cilia
go.
under a microscope. So, you guys know that how our cilia move are like this, right?
Yeah,
This is
the
what they
little
do.
hairs.
I actually got to see a microscope with cilia on it that were doing this. And ones that were just doing this.
They're just
Smoking.
waving. They're
Just-
demure.
Just the tip of them were moving.
Demure.
Very
Yeah.
Yeah,
But this is how, so what you guys are gonna see is another new diagnosis is coming your way, okay? Remember how I told you guys
Where cilia move in a
bronchiectasis
different.
didn't used to be the terminology we used, right? We didn't, bronchiectasis is another made-up disease. It's not made up, it's because we found out, they call it primary ciliary dyskinesia, which is just a fancy way to say, you guys, that your cilia don't move correctly.
What, they're
right?
going in a circle instead of.
Because they're going in a circle, or just the tip is moving, right? Just that causes, what do you think it causes? You guys, if your cilia can't move correctly in this manner, okay, so
An
first of all,
increase
let's
in
talk about
mucus.
why they do it.
Well, it's to
Why
move-
do cilia move like this?
To
What is
move
the motion
mucus.
causing?
movement?
Movement.
Of?
Mucus.
Good, and we call it the mucociliary escalator, right? Because what happens, when I stand on an escalator, it moves, I don't, which is perfect for me at conference, okay? As Emily and Lauren are walking up the fucking flights of stairs, I'm like,
She takes the elevator.
Princess babe.
the escalator. I almost took the elevator one time, but yes. Hey, I walked the stairs with him one time and almost died, you guys. So I wasn't good. Okay, so your cilia though, because they're creating this motion, if you stop that motion or inhibit that motion, that escalator doesn't work correctly, right?
Mm-hmm.
So if I'm doing this with my cilia, where do you think the mucus is going?
Nowhere.
What about this?
Nowhere.
Slowly, right? Because it might still move, but this part is not helping the action, so it's not going to get to go, right? So the fancy terminology is primary mucociliary dyskinesia, or primary ciliary dyskinesia. Just a fancy term to say it doesn't work correctly. But what it does, you guys, is it creates and develops bronchiectasis.
Would it affect your breathing pattern? Like, would it be more turbulent?
Oh, I would imagine so, yeah.
Because it's caught up in mucus.
Because it's caught up in the mucus in there.
Did he say why that
Yep.
happens?
We don't know why it happens, you guys. In most time, it's idiopathic. We don't know yet, which is why this guy is actually trying to grow airways, you guys, and figure this out.
It's
Is
big.
because
Just kidding.
we found out now what causes it, and he found out that you can have cilia that look like they're working, right? But when you get them down to a microscopic level, only this part is working. What they originally started, I guess, doing was cross sections of the cilia, and as long